Welcome to the last tutorial in Module 3 of Part 1 of this course on fluids. This tutorial will look at how fluids distribute between the intravascular and interstitial space in different circumstances. The questions that I'm going to look at include: what happens to IV fluids when they're injected into veins? Where does the fluid go? How long does it remain in the plasma or the interstitium? Does anaesthesia or the stress response influence how long the fluids stay in the body and where they are distributed to? Which stays in the bloodstream longer, a fast bolus or a slow bolus? Tutorial 12, Fluid Kinetics. Previously we discussed the macrocirculation and the capillary endothelium and its glycocalyx. We reviewed the revised Starling equation and compared it to the original Starling concept. We looked at albumin in critical illness and what happens in capillary leak. We also looked at indications and questions regarding both albumin transfusion and colloid transfusions in critical illness. In this tutorial, I will cover crystalloid infusions in normal individuals, the impact of anesthesia on the circulation, and a concept known as volume kinetics. Be aware, few things in medicine are so dressed up in dogma as intravenous fluids and what happens to them when they're given to the body. Hopefully, if you can follow me through this tutorial, you'll learn lots about this and you can disregard a lot of the stuff that you were taught throughout your training. Let's start with a scenario. You go and see a patient in the preoperative area. Her name is Marcia. She is 34 years old and she's scheduled to have varicose vein surgery in about an hour's time. She's complaining about being thirsty, having fasted overnight, and the intern prescribes a litre of dextrose 5% over 1 hour. Here's the question: what will happen to that fluid? Well, what will happen is really depends on two things. First of all, how dehydrated Marcia is, and also when the fluid was administered. If the fluid was administered 1 hour pre-op, it's likely that Marcia will spend most of that hour going to the toilet. If it's closer to the operation, maybe 30 or 15 minutes pre-op, and it's run in fairly quickly, she will wake up in the recovery room screaming in pain from a full bladder. The human being, under normal circumstances, is not a camel. We don't store fluid. If we're given fluid either enterally or parenterally, under normal circumstances, it goes straight through us. However, there are situations where those dynamics change. During the stress response, during surgery, fluid collects in the body. And this is what this particular tutorial is about. The term I'm going to use now is volume kinetics. Kinetics is what happens to a drug or an agent that has been introduced to the body. In this case, we are interested in what happens when a specific volume of intravenous fluid is given to a patient. When IV fluid is administered, the plasma volume expands. This is noticed by volume receptors in various locations in the body, and there are a series of reflexes that exist to maintain homeostasis, and in this case results in the virtual elimination of antidiuretic hormone from the bloodstream. The consequence is rapid elimination of unnecessary fluid from the body. This will be familiar to any of you who have ever gone to the pub for several hours and several pints. You spend nearly as much time in the toilet as you do sitting at the table. And it is exactly what is happening with Marcia when she gets her litre of fluid. The key message here is that under normal circumstances, humans can't store water. There is no point prehydrating a patient, either enterally or with intravenous fluids, because that fluid turns to urine very quickly. Things are very different during anesthesia, surgery, and recovery. You will recall the triphasic stress response. This is ebb and flow and recovery. This is what happens with the stress response for someone who's having an elective operation. Note on the y-axis fluid balance, that's either positive or negative. And we have our incision at the beginning. and then the stress response. And what's really apparent here is that anaesthesia obliterates the ebb phase, and the flow phase starts almost immediately. But remember, this is exacerbated by hypotension that is induced by anaesthetic agents. And so the amount of fluid the patient gets may relate not just to the flow phase, but also due to vasoplegia. Intravenous fluids in the non-hypovolemic state that are given intravascularly will then redistribute into the interstitial space. Let's look at another scenario. Sophie, who's 68, undergoing vascular surgery. Perioperatively, she gets 3 liters of sodium lactate solution. That's Hartmann's or lactated ringers. Her starting hemoglobin is 13 grams per deciliter 1 day pre-op. There is minimum blood loss in the operating room. What will her likely concentration of hemoglobin be at the beginning and at the end of the operation, and then a couple of hours later in the recovery room? The first thing you need to consider is the whole concept of sampling blood. We assume that when we take a blood sample, that represents a steady state of blood volume. The cellular material, the hematocrit, should usually be a certain percentage of the whole blood volume, and the plasma volume is what is left when one removes the cellular mass. Hence, when you take a sample of blood, you make all these assumptions. In this case, we draw a sample, and the hemoglobin concentration is reported as 13 grams per deciliter. A deciliter is 100 mils. But remember that assumes that 100 mils of blood always has the same proportions of components. This is absolutely not the case when the patient undergoes a stress response. By way of illustration, imagine that we give the same patient a bolus of fluid and that we expand the plasma volume by 20%. Now we are effectively measuring the hemoglobin concentration of a volume of blood that is greater than expected, but hematocrit that is lower than expected. The same amount of cellular material is present, but the blood has been diluted by increasing the plasma volume with crystalloid. As we will see later in this tutorial, this does not happen under normal conditions, but it does happen during various stages of the stress response. This concept of hemoglobin dilution is actually quite helpful when reviewing blood tests in the perioperative period. In the case of Sophie, 1 day pre-op, when she was at steady state, her hemoglobin was 13 grams per deciliter. She's been fasting now for 8 to 12 hours, so is probably a little bit dehydrated. At the beginning of the surgery, hemoglobin might be a little bit higher than that. At the end of the operation, having received 3 liters of fluid, her hemoglobin will have fallen, sometimes by a few grams, without much blood loss. When she goes back to recovery, the fluid has stopped, and 3 liters of no blood loss, I wouldn't give her any IV fluid post-op. And so the fluid that was already in her plasma continues to redistribute into the interstitium, and the hemoglobin tends to go up a little bit. Now, this may continue for up to 48 hours, and the hemoglobin stabilizes at that time in and around the preoperative level. However, after 48 hours, and this may vary, once the stress response starts to abate, fluid mobilizes from the interstitium and the hemoglobin falls again. This represents relative hypervolemia, and it has minimal clinical significance. You may at this stage choose to accelerate elimination by giving the patient some diuretics, for example. Finally, over the next 3 or 4 days, the hemoglobin progressively rises back to the starting point, so that by day 3 at the earliest and day 7 at the latest, the hemoglobin will be back where it started. One absolutely key thing to understand is the period within 6 to 12 hours of surgery. During that time, unless the patient is receiving boluses of fluid, the hemoglobin should be staying up at something close to the level that you would have expected in the preoperative period. If the hemoglobin starts to fall during that period, the patient is bleeding until otherwise proven. The reason why, in this circumstance, the hemoglobin falls is the interstitial fluid, of which there may be now a lot, is rapidly mobilized to restore blood pressure in this circumstance. Moreover, often when, for example, nurses notice a fall in the blood pressure associated with bleeding, the response is usually one or more fluid boluses that dilute what hemoglobin is left. Hemoglobin stays in the bloodstream, so frequent sampling allows measurement of dilution associated with crystalloid resuscitation, and this is known as volume kinetics. I owe a huge amount to Robert Hahn, who's done all of the work on this, published many papers, many review articles, and a lot of what I'm going to talk about for the next 15 or 20 minutes is going to be directly derived from his work. So I want to give him full credit for this. Volume kinetics in the perioperative patient or the patient undergoing the stress response is a two-compartment model. We come along and we give intravenous fluids. That expands the plasma. But unlike the situation with Marcia, not that much fluid is actually eliminated. Most of it actually redistributes into the interstitial space. Now, knowing this, we know how much fluid we gave. We know the hemoglobin before and after the fluid was given. We know how much urine is made. So knowing all the other stuff, we can calculate out how much fluid has gone into the interstitial space. One point worth noting, though, is that the apparent interstitial volume is 12 to 15 litres, but in fact, the real interstitial volume is significantly lower, maybe 25% lower, because some of the interstitial space is non-expandable. That would be things like bone and the skull and encapsulated organs like the liver and the kidney. So the expandable interstitial volume is only 8 to 10 litres. So the amount of fluid that actually redistributes is more like a 1 to 2 ratio of intravascular volume to interstitial volume rather than the higher numbers that are often quoted. So we're talking really a 1 to 2 ratio, 33% staying in the bloodstream, 66% extravasating, although it does get a little bit more complicated the more fluid that you give, as we have seen when the interstitium loses its compliance. A term that's worth keeping in mind is the term the half-life of infused fluids. Now, we administer the fluid and it expands the plasma volume and then redistributes to the interstitium. Once fluid is eliminated from the plasma volume restricts and then fluid returns from the interstitium to the plasma. The half-life is based on the rate of elimination. So the half-life is the time required to eliminate, not redistribute, eliminate 50% of the infused volume. A key point is, if a fluid has a half-life that is very long, it means it volume expands the patient for longer, but it expands both the plasma and the interstitium. So you'll get the benefit of plasma volume expansion, but the detriment of interstitial space expansion and all of the complications associated with tissue edema. Well, if you want to do fluid kinetics studies, you need volunteers, and how most of these studies are constructed is the volunteers get an IV placed, probably a second IV in the other hand. A fluid infusion goes into a vein, and every couple of minutes somebody checks the hemoglobin concentration from an alternative site, and then it's all fed into a computer and a kinetic model is made. So if you recall this particular picture, I showed you this earlier on where we looked at plasma, interstitium, and elimination. Now we're going to work back on this. Behind that model, you'll see two boxes. One box has the word plasma in it. That reflects plasma volume. The other box, the pink one, is the interstitium. Now, along the y-axis of these boxes, you can see percentage infused going from 0 to about 80%, and then in the x-axis, the number of hours. So 1, 2, 3, etc. hours, and it's replicated because we're looking at parallel fluid expansions in the plasma and in the interstitiums. That's why it's 1, 2, 3 in each box. Now we're going to give our patient a fluid bolus, and immediately as soon as the fluid bolus goes in, fluid enters the plasma volume infused percent goes up. So you can see here, the fluid is given very quickly over about half an hour, and the plasma percent goes up rapidly, and then very, very rapidly it's cleared out of the plasma. And you can see most of it has been eliminated, but some has been sent into the interstitium, but a modest amount in the interstitium versus the amount of volume that's given. After 13 minutes, assuming that the infusion has been completely turned off, taking into account elimination, only 20% of infused fluid will stay in the plasma of a healthy volunteer. The half-life of the crystalloid, and that is sodium lactate solution, is about 8 minutes, and it's fully equalized after 30 minutes or 4 half-lives. Now, the distribution is relatively slow, and that means that crystalloids are fairly good plasma volume expanders when they're given as an infusion, with an efficiency, which means the amount of fluid retained divided by the amount infused, of 50 to 75%. But it really only stays in the plasma as you infuse it. Once it's stopped, it's either eliminated or it redistributes. Let's return to the operating room. Remember Sophie, 68, undergoing major vascular surgery. She has been in the operating room for 3 hours and has had 3 liters of sodium lactate solution. That's either Hartmann's or lactated Ringer's. Minimal blood loss. And the question here is, how much urine will be in her urinary catheter bag at the end of the case? Let's first of all look at the impact of anesthesia on the macrocirculation. A straightforward anesthetic looks a bit like this. Patients are usually given a short-acting opioid like fentanyl or alfentanil or a continuous infusion of remifentanil to blunt the adrenergic response to intubation and incision. The anesthesia is induced with either propofol or ethiobarbiturate. The patient may receive a muscle-relaxing drug such as rocuronium or vecuronium. If they receive that, they will require positive pressure ventilation, usually with PEEP, and they're kept asleep with either a continuous infusion of propofol or sevoflurane or desflurane or equivalent volatile anesthetic agent for the duration of the case. This is a cartoon of the circulatory system. On the left side of the screen is the right atrium and ventricle feeding the pulmonary circulation that leads to the left atrium and left ventricle. That generates a pulsatile flow of blood into the circulation. In this example, the circulation is divided into the splanchnic vessels and the extremities, but always remember that 2/3 of the volume is on the venous side. When anesthesia is delivered, vasodilatation occurs throughout the circulation. For example, there is significant splanchnic vasodilatation that results in pooling of venous blood around the liver, spleen, kidneys, and the bowel. There is vasodilatation in the extremities. This is the main source of your peripheral vascular resistance. So the peripheral vascular resistance falls, but simultaneously it falls because the microcirculation opens up and there is more runoff for blood to go into. So there's more space in the circulation for blood to flow into. And because of that, resistance falls. Giving the opioids and the other anesthetic agents reduces central adrenergic activity, increasing vagal tone, reducing heart rate. Because of a lot of this stuff, particularly the vasodilatation, there is a significant impact on the venous side of the circulation. The stress blood volume, by all definitions, must reduce because there is venodilatation. That means that the mean systemic pressure falls, and the ramp from the mean systemic pressure into the right atrium falls. This must reduce venous return. Simultaneously, the thoracic cavity, which normally is in a negative pressure state, now is in a positive pressure state, and having positive pressure outside the heart reduces venous return. So venous return is reduced for 2 reasons: vasodilatation, reduced stress blood volume, and positive pressure. The right ventricle will continue to pump, and so blood will move into the right ventricle, but the combination of the low mean arterial pressure and the low heart rate means overall global blood flow is very, very, very sluggish. Let's just have a quick look at the microcirculation. As previously mentioned, the microcirculation under resting conditions has tonic sympathetic activity. That means that the pre and the post capillary sphincters are taut, and so flow is restricted going into the microcirculation, and this is mostly controlled by alpha-1 adrenoceptors. We have a small amount of circulating epinephrine and norepinephrine, adrenaline and noradrenaline. And when anesthesia is delivered, some of the anesthetic agents are direct vasodilators, such as sevoflurane and propofol, but also we give these opioid agents that reduce the adrenals medulla's output of catecholamines. The net effect is less adrenergic tone, less adrenergic activity, and loss of the pre-capillary and post-capillary sphincter tone. Consequently, there is more flow into the microcirculation. This is the main reason why the blood pressure falls on the arteriolar side. This flow into the microcirculation doesn't necessarily mean more fluid extravasating, because the pressure within those vessels is very low because of the runoff that I've previously discussed. So in terms of our basic anesthetic, it's important to understand the anesthetic in and of itself doesn't have a huge impact on the half-life of IV fluid. There are certain components of the anesthetic, the direct vasodilatation and the positive pressure ventilation that do, but if the patient is gently anesthetized and they breathe spontaneously, really IV fluids don't stay in the body any longer. However, the half-life is seriously prolonged if the patient is undergoing surgery, and particularly if the patient gets mechanical ventilation. So the cause of prolonged half-life of IV fluids is a combination of the stress response and hypotension. Most importantly, fluid administered during surgery stays in the body for a long time, and most of that fluid sits in the interstitium. This is a very nice study published in 2012 that looked at fluid administered intraoperatively to patients undergoing bariatric surgery, and patients were randomized to 10 mils per kilo per hour. They got about 3.3 liters of fluid versus 4 mils per kilo per hour. There's 107 patients involved. Roughly 50% were in each group. The patients who received 4 mils per kilo per hour received on average of about 1,325 mils. So how much urine at the end of this operation was produced in each group? The patients who were given 10 mils per kilo per hour, nearly 3.5 litres of fluid over 3 hours, produced 100 mils of urine, 100 mils, leaving them with a positive balance of 2.2 litres. The patients who received 4 mils per kilo per hour, that was 1,325 mils, produced 107 mils of urine, leaving them with a positive balance of 1,200 mils. Under anesthesia, the half-life of crystalloid is 10 times longer. This is principally caused by a lower mean arterial pressure and reduced renal perfusion, and it can be curtailed by administering alpha-1 adrenoceptor agonists such as phenylephrine, which will increase the rate of elimination by about 30%. Now, to remind you of the picture, in an awake patient, plasma is expanded while the fluid infusion keeps continuing, but most of the fluid is eliminated, but some goes into the interstitial space. Under anesthesia, with a patient with a fall in their mean arterial pressure, when fluid is given, there is an increase in the expansion of both the plasma and a dramatic increase in the expansion of the interstitium. While the fluid is being given, there's a big increase in volume expansion in the bloodstream, but the price you pay is a lot more fluid in the interstitium than you necessarily would want. Changing the picture a bit, if you look, this is what we already have, which is the patient who is a little bit hypotensive. If we infuse the same amount to the same patient, but their blood pressure is a little bit higher, for example, 75 millimeters of mercury from, for example, giving them phenylephrine. Well, this is what we see. We see less volume expansion of the plasma, but significantly less volume expansion of the interstitium. And that's because the higher pressure results in a higher stress blood volume, a lower volume of distribution, and less extravasation and more elimination. So what we're seeing here is greater elimination because we have plasma expanded a patient with a normal blood pressure or a blood pressure that has been restored. Be aware also that older people will retain more fluid. And so the picture that we see here with the patient with what looks like a normal blood pressure actually results in this curve here. The patient who is older will retain more fluid than the same MAP level for a younger patient. So although the MAP is low, the stress blood volume is low, so fluid does not redistribute unless fluid bolus are administered. Treating hypotension with fluid boluses may result in significant fluid sequestration in lax tissues, and this happens at a higher blood pressure in older patients. Vasopressors significantly reduce the volume of fluid sequestered and increase the urinary output. Be also aware that volume kinetics are prolonged even with spinal or epidural anesthesia, but can be normalized with vasopressor drugs. Something else that you might find surprising is that if you infuse a small volume, for example, 2 to 5 mils per kilo, up to about maybe 350 mils over 20 minutes, nearly all of it is rapidly excreted and very little redistributes to the interstitium. Rapidly infused large volumes have relatively short plasma half-lives and rapidly redistribute. Saline has a very long half-life in both plasma and in the interstitium, about nearly twice as long, 110, nearly 2 hours, 110 minutes compared with sodium lactate solutions. The time to first passing urine in volunteers who are given saline is twice as long as compared with lactated Ringer's solution, and 3 times as long for 5% glucose. We don't know the reason for this. There's lots of theories about how chloride, and it's probably the chloride, affects the kidneys and maybe it causes renal vasoconstriction. Maybe it's an osmolality related effect because saline is slightly hypertonic. We don't know, but we do know that they hold on to it for longer. What about fluid kinetics and the revised Starling equation? JV is the tissue blood flow, and it's affected by the capillary minus the interstitial hydrostatic pressure, and then of course the difference between the oncotic pressure within the glycocalyx and the subglycocalyx layer. That's multiplied by the surface area for filtration and how porous the membrane is. That's the LPS. During induction of anesthesia, septic shock or acute blood loss, when the capillary pressure is low, and this, for example, is a mean arterial pressure dropping by 20 to 30%, the JV declines to close to 0 because there isn't enough pressure to squeeze the fluid out into that tight interstitial matrix. Consequently, the distribution of infused fluid into the interstitial space is arrested, and the fluid efficiency is almost 100%. So in very low flow states, or states where the patient is very hypovolemic or hypotensive, when you run an infusion of fluid, very little of it actually extravasates. Hahn believes the reason for this is that the matrix, the interstitial matrix, that gelatinous matrix that I've talked about many times, is non-compliant at low flow and low hydrostatic pressure. Remember, though, the impact of anesthesia. When a patient receives the anesthetic, blood pressure may fall to 75/40, heart rate may fall to 50 beats per minute, and you have 2 options here. The first option is you can squeeze a bolus of fluid into the patient, or the second one is you can administer a vasopressor to the patient. Well, which is the better option? Remembering that the microcirculation is wide open now because the patient has vasodilated extensively from the anti-adrenergic drugs and all those direct vasodilating drugs like propofol and sevoflurane. And what happens is if you squeeze the bolus of fluid in really quickly, that fluid just goes into the microcirculation under fairly high pressure, and it extravasates out into the interstitium. So you just get a whole pile of that volume going out into the interstitial space with very, very little benefit. And the reason for this is that at very high flow, the JV is very high and fluid extravasation is high. And unfortunately, that results in significant edema formation. Remember, your patient at the beginning of anesthesia is relatively euvolemic. They're just vasodilated. And you can cause a lot of tissue edema very quickly by putting fluid in under pressure. The second option is to just give the patient a pro-adrenergic agent, an alpha-1 adrenoceptor agonist, such as phenylephrine, norepinephrine, metaraminol, etc. And what they do is, these drugs do is they close down those pre- and post-capillary sphincters. So essentially, the microcirculation now is vasoconstricted, and you've restored the physiology back to normal because you've repleted the adrenergic effects that happen on that microcirculation. And as a consequence, the blood pressure comes up. You're much less likely to be squeezing fluid into the patient. And if you're running an infusion, because of the relatively low flow to the microcirculation, you have less fluid extravasating. So you're probably better off giving a patient like this a vasopressor agent or a pro-adrenergic agent. High flow occurs when you give a patient a rapid fluid bolus. And when you do that, this is what happens. And this is a picture of a 200 ml fluid bolus versus a 1000 ml fluid bolus over 10 minutes. The red is the 200 ml fluid bolus. You can see here, fairly impressive expansion of the plasma. Remember, it's not the absolute volume, it's the proportion of that fluid that stays in. So a lot goes into the plasma and very little redistributes into the interstitium if you give a 200 ml bolus over 10 minutes. Whereas if you give a 10 minute bolus of 1000 mils, most of that fluid rapidly goes straight out into the interstitium and stays there. Rapidly infused volumes of large amounts of fluid do not stay in the bloodstream. They extravasate, they cause tissue edema, and you get very, very little benefit. Not only do the rapid boluses rapidly extravasate, they're also more likely to cause edema for a second reason, and that is because of overwhelming the lymphatic drainage to the interstitium. And now you have a situation where the extravasation rate exceeds the lymphatic clearance rate. So in terms of our patient who is undergoing surgery, fluid is retained due to the stress response. In the conscious state, 75 to 90% of fluid is eliminated within 2 hours. In surgery, only 5 to 10% is eliminated. A large amount of fluid can be retained during a short operation, and this will not mobilize quickly postoperatively. The duration of a retention also increases progressively with age. 30 minutes or so following surgery, as blood pressure normalizes and circulating catecholamines fall, the responsiveness to crystalloid normalizes and less fluid is retained, so that the time that the patient is likely to really retain a lot of fluid and experience fluid overload is in the operating room or immediately post-op after they've had a major operation. They're going to get a lot of fluid in theatre that is just going to stay there. Now, that's true of elective surgery, but for emergency surgery or trauma, due to the prolonged stress response that occurs in trauma or emergency surgical situations, you have all that cortisol and antidiuretic hormone and epinephrine and norepinephrine circulating for a prolonged period of time. Continuing fluid sequestration may occur for many, many hours and possibly days following the operation. And this is really characteristic of critical illness. So care must be taken to match inputs with outputs in these circumstances. In particular, you need to be very careful of not automatically prescribing maintenance fluids to people who may or may not be several liters fluid overload at this stage. I did mention that the interstitial volume at rest is actually lower than you think because of these capsulated organs in bone. And if you lose blood initially, it should only be replaced 2-to-1 with crystalloid. However, because of the process of hydraulically fracturing the interstitium, the more crystalloid you give in large volume, the more damage you get to the glycocalyx, precipitating capillary leak and hydraulic fracturing. And the gelatinous material becomes more and more porous and pockets of edema form, and that edema becomes clinically relevant and clinically evident. And the more fluid you give, the more compliant the interstitium becomes, to the point where you need a staggering amount of fluid to maintain circulating volume. It goes up geometrically, and this was beautifully described by Moss in Archives of Surgery in 1969. Let me cover some key points in this presentation. It'll take a few minutes, but I want to reinforce these points. What happens with intravenous fluids within the body is determined by whether the patient is euvolemic or hypovolemic, or whether or not they're having a stress response or undergoing anesthesia. Although intravenous fluid is rapidly eliminated in euvolemia, the fluid redistributes into the interstitial space during the stress response and anesthesia when there is surgery. Fluids administered during the stress response and anesthesia have prolonged half-lives. When capillary hydrostatic pressure is low, such as in hypovolemia or anesthesia, fluid extravasation is actually quite limited. The rate of extravasation is directly related to the volume administered per unit time. Slow boluses are more effective at plasma volume expansion than rapid boluses. Under anesthesia, low-dose vasopressors prevent fluid extravasation and edema formation. Fluid given during surgery stays in the body for the duration of the stress response. Once elective surgery is over and the patient is awake, most fluid subsequently administered is eliminated. However, if the patient is critically ill, the stress response is prolonged and the patient is likely to sequester fluid in the interstitial space for several days. Hence, in this setting, it is essential to be careful about the amount of fluid that is being given and to continuously monitor fluid balance. Let's review this tutorial. In this tutorial, I covered how hemoglobin concentration can be utilized to address volume kinetics. I looked at the impact of anesthesia and surgery on the microcirculation, and I looked at volume kinetics in health, in anesthesia and surgery, and to a lesser extent critical illness. This is the end of this particular module. Next time, I will do a bonus tutorial on volume monitoring in the ICU and the operating room. We'll look at CVP traces and data from pulmonary artery catheters, and we will look at the arterial line and its role in volume assessment. Okay, so that was a discussion on fluid kinetics, and it is the end of the advanced module of part 1 of this course. I hope you found it helpful. I am delighted to hear your comments. After a bonus tutorial on volume monitoring, we'll move on to part 2 of the course, electrolyte abnormalities and electrolyte therapy. Please join me.